We're seeing more anxiety, more depression, more maternal suicide. It's one of the leading causes of maternal death. What we are doing is not working.
It's true. I just saw the ACOG report, and for the US, the highest rate of death is maternal mental health categories, not hemorrhage, not medical things. It's like, wow, this is a really big issue, and we're seeing that skyrocket. Welcome back to the podcast, ladies. Today, I have the honor of interviewing Rachael Austin, who is the head of education for the Thompson Method of Breastfeeding. Rachael is an endorsed midwife, a child and family health nurse, an international board certified lactation consultant, an educator, and has many certifications and qualifications, and has essentially been working with women, supporting women in birth and breastfeeding for over 25 years. She has taken over as the head of education for Dr. Robin Thompson, who was the founder of the Thompson breastfeeding method, which is one of the best breastfeeding educational resources that I have found out there. They are based in Australia, and I am so honored to have Rachael here with us today. Welcome to the podcast.
Hi, Karen. Thanks for having me.
So, Rachael, we're going to be talking all about breastfeeding and how our birth impacts our breastfeeding journey, and even dispelling some of the myths surrounding breastfeeding. And so I'm so excited to dive in with you here today.
It's wonderful. And, you know, as a midwife, I'm really passionate about physiological birth, but not everybody gets to have that birth. But it's really for me is having women empowered and knowledgeable about how our birth affects our breastfeeding, and even more than that, how to navigate the difficult waters after you've given birth if it hasn't quite gone to plan. Often, you know, we jump straight in with all these interventions and they make breastfeeding even more difficult, and they're not always necessary. So having that education for pregnant women, if I could just do one thing in my lifetime, it would be that all pregnant women have breastfeeding education. And that would actually do me out of a job, and I'd be really happy.
Well, you provide a lot of educational resources, so I'm sure you are still very needed. But you're right, because most women don't even think about breastfeeding or breastfeeding education until they're sitting there with their baby and it's not working and it's painful, and we're scared that baby is not getting enough to eat, or the doctor, the physician is concerned. And so, and by then you're in the postpartum, and it's way harder to try to prepare or educate yourself. So I hope that this episode serves as something that is going to bring value to a lot of pregnant women to understand this journey a little bit better, and hopefully give you some resources as well that you can even continue that learning for. And it's one thing I wish I had known more about when I was pregnant with my first, because like many women, I just thought, oh, it'll work out. My body will figure it out. I'll figure it out. You know, I'm going to breastfeed. I won't have any issues. And it was really challenging for the first couple weeks. And so what are some of the interventions or the decisions being made in labor and delivery that can impact a woman's breastfeeding journey?
There's so many. It often starts with the intervention of labor, or well, just check your cervix and just see how you're going. I'm not even in labor yet. And while we're there, you know, and you're on your back and your legs are open, and while we're here, we might just do a strip and stretch. You know, those are the things that we see. So we're inducing labor. It's not spontaneous labor, it's augmented labor. The rupturing of membranes, that's really a big one, especially for when we're being induced. And the bag of waters serves to maintain the hydraulic pressure in the utero. So if you take away that bag of waters, contractions are harder, stronger, more difficult, more painful, and the baby can't drink and hydrate through labor. So that's a big thing. So that's really important to consider that. Then the induced labor is hard, so women are more likely to have an epidural or obstetric analgesia for pain relief, because it's just needed. Like, they genuinely need the extra pain relief because it is difficult. But that affects the newborn and young baby's oral function and capacity to be able to coordinate lip sealing and the vacuum as they vacuum on. So then we come up with these interventions that are the big wide open mouth, hamburger in the breast, holding the baby here and trying to jam them on. Now, no mammal on the planet feeds like that, but it's an intervention that started about 50 years ago. It doesn't work. The nipple goes exactly where we put it, behind the nose. Where's that? Here, in the hard palate. So we straight away start getting nipple pain and trauma, and that's what we're seeing from the onset. Like from as soon as women have that first and early breastfeed, they're having nipple pain. Their nipples don't need to harden up. That's not a thing. They're having pain because of newborn oral function. They can't coordinate, and the forceful techniques.
Wow.
Often are induced.
I just want to.
Oh, yeah.
That's just, I mean, what you just said there, I feel like you just dropped so much knowledge about this whole problem. We're seeing so many issues with breastfeeding, not only in the interventions, but in the how we're teaching it to women. And it's creating so much trauma for mom and baby and pain.
Much trauma. The next thing is being induced with Pitocin, synthetic oxytocin. That affects newborn oral function as well. And the research is highlighting that. And there's more research coming out on that as well. So watch that space. But we're really seeing babies who can't coordinate their oral function that are being induced, and the obstetric analgesia as well.
Can you break that down a little bit more? How do the epidural and Pitocin medications or interventions inhibit that baby's coordination with the oral function to breastfeed?
Yeah. So the augmented or induced labours are extremely hard, and there is a connection with the oxytocin, the Pitocin, that affects oral function. And it's changing, and there's research going on about this at the moment to understand more deeply how that's impacting. And if you watch Dr. Sarah Buckley, she's doing part of that research. But oxytocin changes so much, and it's a natural love hormone. So our babies are born and they're soft and squishy, and they're ready to have that beautiful oxytocin received in their breast milk and that skin to skin and all that. It's just beautiful. But Pitocin is not like that. It is totally different, and it is affecting oral function. And you imagine the uterus being contracted artificially, really it's not like a normal contraction. It's so much harder, forceful, longer. And that's babies basically being pole driven down through the mother's cervix. So, it's not uncommon for them to be sore in their head, neck and shoulders, or maybe they have a headache when they're born. We don't always understand or know. But then you've got epidurals or the opioids that are being used, or potentially it's a general anesthetic or a spinal anesthetic, and the opioids that are used in that. Now, they make the babies really sleepy. And that's not their fault they're sleepy. You can't wake them up. They're drug affected. And it does change the way that they can use their oral function. They can just be too sleepy, known as sleepy baby syndrome. But they can't seal. And then they can't coordinate the tongue to curl around the nipple. And then the vacuum pads can't engage to vacuum the nipple back. So, they have trouble breastfeeding. And in those instances, for those women that need to have that, we would expect that and support her in a really gentle way, so she's protecting her breast milk volume, making sure her baby's fed, but not putting her under pressure and under duress to say that she has to feed the baby has to feed, make the baby feed, and, hamburgering and jamming them on. It's not going to work. If your baby can't breastfeed, we can't make them breastfeed.
So what would you recommend in that situation?
Yeah, so she can express, or she might need help expressing. Depends. Most women are really wanting to do it on their own anyway. Or so expressing, and then syringe feeding or cup feeding, depending on the situation and her baby. For those babies that taken to the NICU or the special care, they might be having a nasogastric tube. So if they're nasogastric tube, the biggest thing is that they're not brain imprinting on high volume, fast flow and instant gratification. It's really important we're not pace feeding, and that's something that's commonly taught. Pace feeding is laying the baby down and gravity feeding. So they're sucking through, often through a device like a good example is the Dr. Brown's bottle. You see the green straw in the middle?
Yeah.
And what they do is suck like this. So it changes oral function. then they try and do that at the breast. So what we're trying to do if we're bottle feeding, and some women do choose to bottle feed, usually by the time the milk comes in. Colostrum is low volume. So usually colostrum we would syringe feed or cup feed. But if it's ongoing and the milk has come in and we've expressed, I would suggest keeping the left and the right separate. It helps to reduce gastrointestinal pain and to simulate breastfeeding. So feed the left to the left, the right to the right. So we're having left and right. We're not just gravity feeding down one side. High volume, fast flow, instant gratification. They don't want to breastfeed. So the milk comes in flows. So we're replicating those flows so that we'd have them, let me show you with my bottle, sit the baby upright, have them seal and vacuum to the lid, so the lips are at the lid. And if this is the tongue, the teat should sit on the tongue, so we don't want it up or down like that. There should be no gadgets. Babies can't swallow air. That's not a thing. You know, it's a marketing thing. Imagine if we all drank air when we fed. We would, like if I was having my cup of water and we drink, we'd fill up like a balloon. That's not what happens. Yeah. So we stimulate the empty teat the same as they have to stimulate the breast before the oxytocin releases the milk. And then we give them a slow flow. So tilt them back ever so gently. And they have a nice slow flow. So narrow, long, and one whole. And they have a slow flow. And the mum is, or whoever's feeding the baby is controlling the flow. And then we sit back up and do a second one. Maybe 3 or 4, whatever, to the observed cues of satisfaction. Rest and digest so they can spend some time processing, digesting. When they're ready, we watch for the observed cues for the second breast, turn baby around, and we simulate the second breast in the same way.
And what you're showing, for those who can't see, is she's putting that nipple is going directly in the mouth. It's not tilted up toward the palate or down the throat. And the baby is sitting up, so the bottle is like a straight...
At 90 degrees.
To the 90 degrees, yeah. That's like just never taught. Like I see women and couples all the time, football hold, babies laying down. They're, putting that breast in baby's mouth, or I'm sorry, the bottle. And just until the whole bottle's gone and not even really paying attention to are there cues that baby's full and they're gulping air. You see more digestive issues, gassiness. So what you're sharing.
Well, babies can't swallow air. It's they're drinking quickly and rapidly, and that milk hits the stomach, which is acidic, and it's quickly processing and digesting. And if mothers are taking supplements, prenatals, fish oils, probiotics, there's a whole range of things mums take or they give to their babies, then we see more reflux, more colic, more gas, more big farts, more all of those things. So my suggestion to mums is not to over supplement and to take unnecessary supplementation. So is she deficient? She'll know that from her blood tests and her pathology. If she's not deficient, eat well. All through history and evolution, all these things are interventions. So we don't need to do interventions unless there's a genuinely good reason to, and then used appropriately.
What other causes are there from your experience for babies who are colicky or gassy?
Yeah, so frequent feeding. So feeding more than 9 or 10 times a day and often one breast each feed. So high volume, fast flow, basically overfeeding, misunderstanding the observed cues. Mothers who are taking supplements, babies who are given supplements, they significantly increase reflux, colic, jaundice, all of these things. Women think they've got low volume, so they start using these awful devices like the Harker and similar type devices, or they're overexpressing their breasts, increasing the breast milk volume, which changes the unique ratio of milk. So really what we need to do is space the feeds, and we're aiming for around about 7 to 8 feeds in 24 hours, both breasts each feed. For example, left breast, rest and digest, right breast. Next feed, roughly speaking, it's unique to every mother baby. There's no maths, there's no rules. It's following baby's cues, but understanding the difference between pain and hunger. Next feed, roughly 3 hours from start of feed to start of feed. Next feed would be right breast, left breast. Next feed, left breast. So you're evening out, and you're having both breasts each feed. They have a good feed, and then they process, digest, and then their gut can rest. Contrary to popular belief, they don't need to be fed every time they open their mouth and make a noise. That's processing, digesting. Can you overfeed a breastfed baby? Yes, you can. The same as, I say Christmas Day. We have champagne breakfast, we eat, we drink, we snack, we eat, we drink, we snack. And by the end of the afternoon, you're leaning back going, oh my goodness, I'm so full, creating space. And that's what the babies are doing. You see them, they stretch and their legs go out and they pull back in. So women who are following the Thompson method, their babies don't have reflux and colic.
Because they're paced appropriately.
We're following their cues appropriately. So they're not on a schedule. The babies are self-determining their own schedule. But a baby who has pain will always root to seek the breast. They'll always take milk in a bottle because they want to just do this, just nurture sucking.
Yeah, because it's
want to
comforting.
pacify. It's survival. It's more than comfort. It's survival. They need to do it. What Robin studied in her PhD was in one of the earthquakes she studied, one of the buildings come down, and the newborn babies, by sucking on their hands like this, could actually draw on their interstitial fluid and sustain life. They survived, yet their mothers perished. And it's actually a survival skill. So newborn babies, they need to suck. It's imperative they can do that. But when they've got, on their hands, they can bring their hands to mouth. So when we sleep our babies, it's really important that we're not doing this and wrapping them up in a straitjacket. They need
swaddle,
to have access. Yeah. Or if we swaddle them lightly so their hands can come out, so they can do the startle reflex and close that cycle. That's really important. And really important for when they're older and they're going to toddle, and then they can put their hands out to capture their fall rather than just smacking their head up on the dirt, We've got all these skills, but we suppress them. So we don't wrap our babies in a straitjacket and tightly swaddle, loosely swaddle.
So does this connect to self-soothing, like what you're describing with babies sucking on their hands to comfort themselves?
Absolutely. That's instinct and survival. They need to bring their hands to mouth to do that. Yeah. A lot of babies, though, don't sleep well because they do have that reflux and colic pain. So often they'll wake up from a sleep and not go back to sleep, or they'll want to be upright on a mum's or dad's chest, and that's the only way they can sleep. Or I'm seeing really fatigued parents. It's because they're just, honestly, women do too much, do less. They're all interventions, and their antenatal expressing is an intervention. Induction of labour, all the things. And then you've got all the pumping, the Haka, and all those brands. All the silverettes are another intervention. The collecting devices are another intervention. We do far too much. And then you look at all the marketing and the lactation cookies and the teas and all the things that we're trying, companies
we're being marketed to constantly. Like, you need all these devices and products in order to breastfeed, which is something we've been doing for thousands of years without any of this
completely, millions of years even. Since the beginning of evolution, as we've evolved into mammals to some extent, we have been breastfeeding, and not because we're lucky, because we're freaking awesome. We're meant to do it. It's true. And, we make it really hard. And probably the worst thing is that there's no law in any of our countries that oversee all this. So there's no law. So these companies can say anything they want to say. Take your bottle companies, for example. You see all these bottle teats that are short, they're wide, and they talk about anti-reflux, anti-colic, they're breast-like and things like that. None of that's true. They all have a completely different oral function. So if we're using those bottles, they have a totally different oral function to breastfeeding. So the short teats, let me show you what I mean. So this is an example. This is a wide-based short teat. They say that looks like a breast. Well, I've seen thousands and thousands of women and have ever seen anybody that looks like that. But all they can do is use that part of their tongue, the tip of their tongue.
Tip of the tongue.
They can only draw to there. That's hard fixed. It doesn't stretch to the soft palate. So the baby to feed off that, they can chew.
Yeah, they're just chewing on the front of their mouth, but the nipple is supposed to go to the back of their throat. Mm-hmm. So it sucks. They suck that. And I think that most women don't understand that. They suck that nipple, your nipple, all the way to the back of their throat and then use their tongue to express. But it's the whole tongue, not just the tip. So
that's right. Yeah.
What bottle do you recommend, if any, for moms who want to?
Well, not a bottle, but the teat we recommend is like this one. It's narrow, long, and one hole. So the tongue. So if this is my thumb is the tongue. Well, the thumb, if you compare it in the baby's thumb, that's about the length where the soft palate is. So you can see the length of my thumb if my nostrils touch on my hand here. That length is where my soft palate is. So you kind of average the length of the teat should be about the same, roughly, of the baby's thumb. And the lips should be sealed to the lid quite firm so they can't extrude it. So, and then no gadgets inside. So no straws.
Inside the bottle. And do you like what you're showing for those who are listening?
Oh, yeah, this one is a Medela. Yeah, and this one is okay. It's nice and soft. I'm not selling you a Medela. You can get whatever bottle is out there. This is one that I had access to.
But what's important is that it's long and thin, not wide at the base.
That's right. We don't want a wide-based. And you see all the different ones. They've got different shaped teats and they slant and they've got them making them like a breast. And it's all advertising and there's no law that governs any of those companies. They can say whatever they want to say and there's no truth to that at all.
Yeah.
And it's different to newborn oral function. So women use those bottles and then they've got nipple pain and trauma because the baby is trying to replicate that oral function on the breast. Or now they're using bottles, they're using pacifiers, they're using nipple shields or multiple bottles even, and now the baby has oral confusion and is slipping between all the different oral functions.
Wow. And we're training them to suck, and how they do it is like they learn that from how all the myofunctional things happening in their mouth with how they're interacting with the breast or the bottle. So I wanted to ask you when you were sharing about the interventions, for a woman that wants to continue primarily breastfeeding, who's had those interventions and is struggling with baby latching or being painful or baby not wanting to breastfeed because maybe now baby's been in the NICU, maybe there was separation and baby's used to getting bottle fed, or someone told her, oh, you have to give formula because your baby's not gaining enough weight. There's all these things that happen. Is there a way to help sort of retrain baby to feed at the breast and backtrack on the things that were missed out on in those critical days?
Yeah. So we do this a lot. We see some of the most complex cases across the entire world, and it's always slowly and gently. The baby is really trying. So if the baby's coming to the breast and breastfeeding, that's beautiful. The baby's really trying. But the most important thing that we're trying to do is aim for face-to-breast symmetry, not asymmetry like the latch, which is holding the back of the head and opening the mouth and jamming them on. They aim for asymmetry. If the nostrils are off the breast, you watch what happens if I show you. Nipple comes forward in the hard palate. So then we get compression. We need the chin to indent the breast, and that lengthens the tongue to optimize oral function. So even babies that have a tongue tie, it's perfectly normal. It's genetic. It is just a variance of normal. Of the 2 to 5% of babies that have anchoglossia, it's not tongue tie, it's anchoglossia, a tiny fraction of those may need to have a surgical incision to help with their oral function. So chin indenting, nostrils contouring and touching the breast. So they contour the breast, and it's the nostrils, not the tip. Both cheeks should touch the breast symmetrically. So we're aiming for face-to-breast symmetry by gentle fine-tuning to help optimize oral function. Now, if there's been shields or bottles or teats or, pacifiers used, they can revert back to the shape of that, and it just takes a little bit of time. Because in the early days, the first feeds, the early days, they're very quickly brain imprinting on oral function and how things work. They know exactly what to do. They've evolved over millions of years with all these survival skills. We don't need to teach them. I don't do things like suck training and things like that because it's a different oral function to breastfeeding. So we're quickly confusing and changing those things. So
does myofunctional therapy help with the babies too? Have you used that in tandem with breastfeeding?
Babies can be tight in their jaw and their head, neck and shoulders, which does affect breastfeeding and can affect breastfeeding. What I am seeing is that they're using a pacifier that is short and got a bulbous base to it, and that's not good for breastfeeding. It's actually completely wrong for oral function, so it's not helping at all, but it's being promoted in the myo world. Yeah.
Interesting. We have so many products that it's hard as a mom, I imagine, to have to
navigate
what's good and what's not helping and what's possibly even hurting their babies.
Oh, so true. And Karen, every health professional says something different.
Yeah.
And breastfeeding education is poorly taught. I was just participating in a research recently around midwifery education in breastfeeding, and she was saying to me that midwives are reporting back saying that they're not actually learning about breastfeeding. And then what is being taught is on the ward, and it's just what the other midwife says or do or whatever. It's not necessarily evidence-based. Lactation is medicalized, mathematical. It's a tick box approach. I often hear, I had a woman the other day, she was very academic, smart woman as a health professional, and she'd come to me and she'd said she'd seen something like all the midwives at the hospital, the pediatrician on the hospital. She'd seen something like 8 lactation consultants, her GP, her child health nurses. So you're looking at over 15 people. And she said, you're my last ditch hope. This is it. I've literally spent thousands of dollars and nothing is helping. Yeah.
She's trying to breastfeed.
She was trying to breastfeed, and they'd done all these things. They'd basically said to her, look, you're one of those people that can't breastfeed. She had one consult with me and she was breastfeeding and crying because she was so happy, and she didn't have pain. Now, it was a journey, but she's still breastfeeding.
Wow.
So, it's all these well-meaning people, but everyone wants to have an opinion with breastfeeding but not actually understand anatomy, physiology, how breastfeeding works. And that's why with the Thompson Method, our practitioners are different to our educators. And we've really, that difference doesn't exist anywhere else in breastfeeding.
Wow.
It's hard for women. You've just given birth. You're expecting that whoever you see just gives you great information. But actually that doesn't necessarily happen. And I'm not being disrespectful to any of my health professional colleagues. You just don't know what you don't know.
Yeah. And what are some of the other myths that women are told about breastfeeding, or maybe their lack thereof, or their lack of ability, or that they have a low milk supply, they need to supplement, or babies needs to gain weight? Maybe you had a small baby or a slightly premature baby. I mean, what are some other myths you see are really common that are really damaging women's breastfeeding journeys?
Oh, there's so many. One thing that we do see often is the expectation that babies grow in a linear rate, so often 150 grams per week, and that's just not always achievable, especially for different cultures like our beautiful Indian women. They're really small, petite women, and that's normal for their babies to be healthy but growing not to the curve because that's just genetically normal. And if they have seen their pediatricians in India, they're saying, actually, your baby's really healthy. But in a country like the US or Australia, they're saying, no, you don't have enough milk, you need to top up, you need to triple feed. Women are depleted, exhausted, overwhelmed, and they really struggle. So they stop breastfeeding prematurely. But actually, there was no problem to start with.
Yeah, they just have small babies.
Yeah, those babies mothers that have intravenous fluid during labour, Often if you've got an epidural, ear-induced, things like that. So they have intravenous fluid during labour. Their babies, that fluid will go to the babies. So the babies have a higher birth weight. And then they have to reach equilibrium or homeostasis, they have to expel that interstitial fluid that's laid down.
Yes.
So they have a huge weight loss, often over that 10%, but it's not actually they're losing weight. They're just losing that fluid they put down.
They're losing water weight. It's not real. It's like all from the fluids women get in labor. And if a woman has a long labor or an induction and she's hooked up to IV fluids for days or even a day, it's going to artificially inflate baby's weight, and we don't realize that. And then the doctors freak out because your baby lost too much weight. We have to supplement. It's maddening.
That's right. It's all the time because that's really common hospital procedure. So actually we should be sitting down as a health professional, doing the whole assessment, understanding the pregnancy, the labour, the birth, and actually let's not even weigh the baby until day 2 at least. And then that's a birth weight, and then we can keep an eye. But really what we should be doing with women is sitting down and watching her breastfeed. We shouldn't be touching her or doing it for her. Guide her using our words, hands off, the same as labour and birth, hands off. Let her do what she needs to do. She's got the knowledge, the power. She's got it, and she can do it herself. But bringing baby to the breast, we're watching the drawing, the swallowing, the cues of satisfaction. And we're looking at the breastfeed. We're working with her and telling her, explaining to her what we're seeing. And we're listening to her. What are you feeling? And she knows. And we go through that feed together. But test weighs, I don't ever do test weighs. They're highly inaccurate. And what it teaches us is that babies grow, 1, to a linear weight. And 2, they're applying a weight that is actually a formula weight, because formula is static. It's 150 mils per kilo per day. Breastfeeding is not anything remotely like that. There is no calculation for breast milk. And, those who understand breast milk production, it varies between morning and evening, between boys and girls, day and night, summer, winter, everything. There's no calculation between breasts. Exactly. So there is no calculation for breast milk. And our baby's stomach is only the size of their tiny closed fist. That's my stomach. So you look at the baby's tiny little closed fist. That's their stomach. Yeah. They don't need great big volumes of milk that are calculated. So we often set women up for failure because we're saying you need to make more milk, you need to make this many meals per kilo per day. And I know I've seen so many women that have come to me crying, sobbing, their breasts are full, engorged, lumpy, mastitis. And they're saying, my baby's crying and upset, I just can't make that much milk, I'm expressing, I'm feeding, I'm expressing, I'm feeding. And they're always unsettled. And it just about always turns out that they've got high volume and their babies are highly unsettled because they're just making too much milk and they're changing that unique ratio of breast milk in the breast. And the babies can't feed from both breasts because they're well filling up on one breast. So it leads to frequent feeding. And then, is that
like a typical cause of mastitis that you see?
Absolutely. Overexpressing, the haka, all those things, breast or facial asymmetry, which doesn't optimize oral function. So facial symmetry is really important.
What do you mean by facial symmetry?
Chin indenting, nostrils contouring the breast, and the cheeks touching symmetrically. So when we talk about the latch, which babies don't latch, the garden gate latches, babies vacuum. So it's really important to understand no mammal on the planet latches, they vacuum. But when we talk about the latch, that's, the hamburger, the big wide open, nipple to nose, that. And then we hold the back of the craniocervical spine where the small brain is housed. And that's, if we hold that, we inhibit. It'd be like me holding the back of your head and trying to jam you onto a steak dinner or whatever. You're going to go, no, thank you. And you see the babies doing that at the breast.
And they push their head back because that's a reflex. When you touch the back of their head, they push away. So you were actually triggering a reflex that makes them lean away from the breast.
And more
or
than that,
pull back.
and one step more than that, we're actually creating a whiplash injury because they're hyperextending and they're being pushed on. And it's actually very similar to a whiplash
Wow.
injury. We're doing a lot
So,
of harm to breastfeeding and babies by doing that.
yeah. What do you teach instead?
Just gentle cradle hold. You look at other mammals like the monkey, the ape, the
Yeah.
chimpanzee. They all hold their beautiful baby in, I can try and show you, gentle cradle hold. This is my baby. So gentle cradle hold. And this has been around since beginning of history. But what I do suggest is women keep their shoulders down low, the elbow at their side. And if I move my camera down a little bit, perhaps you can see me. Head is just gently resting on the wrist, lips over nipple, and then they can have full access to the breast, and then their lips will seal and they'll vacuum on. So bring them in nice and snug. And then what we're looking for is the chin to indent. We might just need to move them gently toward their feet, and that will help the chin to indent. And then the nostrils will contour. So the nostrils to sit lightly on the breast, and you're looking for both cheeks not to be asymmetrical, but to be symmetrical. So they're just sitting on the breast.
So yeah, baby's belly, it's belly to belly, face to breast. Yeah.
That's right. Lips over nipple. So ears, shoulder, hip. So belly to belly, ear, shoulder, hip, chin indents, nostrils contour, and both cheeks touch the same. And there's a lot more to it than that, because you're looking at the length of her arm, the length of her torso. For me, like, I would put that arm underneath and hold on to it, because the babies are so tactile. They like to chew on their hands, and it helps just to keep it out the way. The other thing you're looking at is the gap here. So you might put a little, for example, well, no, pillows are usually too high for most women, and they bring the baby too high and then they look down. So usually just like a little throw or a little something soft, a towel or something potentially, and I would put a pillow underneath there or something underneath there that she can.
Under the arm.
So she's not doing that. Underneath the elbow here.
Mm-hmm. Yeah, so she's not hunched over. I remember having so much back pain when I was breastfeeding, because you're just always hunched over. I used even 2 pillows because I have a long torso. So maybe that baby was too high, but I just remember otherwise my shoulders would just sink. We got to look out for our breastfeeding mamas. Get them some massage gift certificates.
Oh, absolutely. Head, neck and shoulder pain in mums is huge, and really good support. But it's important to be sitting upright. Put the feet on something so that you feel stable, or cross your legs, whatever works.
Yeah.
But sitting upright is important, not leaning back and not leaning forward, because it's really hard for a baby to seal and draw the breast tissue to their unique oral cavity if we're leaning back or leaning forward. So we have to be really careful. We're not touching and moving the breast and things like that.
So we're really letting baby latch and vacuum itself instead of micromanaging everything, but creating that proper alignment.
We're looking at nipple direction. So often if women, like, I would suggest just about to all women to buy a good supportive nursing bra, and a bra that gives you lift and brings your nipples in. A lot of the time breast face down and out, and if the breast is heavy and milk laden, it's really hard for a baby to hold the weight of that breast in their mouth. So you give them some lift and have the nipples straight. So a good bra that's got 2 layers. So you take down the top layer. The second layer has that support. It looks like that. It's a hole. A lot of the bras, you take down that top layer and the whole breast is exposed and it's got no support. So it's useless. So something with good support, especially a woman with bigger breasts that are heavy, you know.
Yeah. These are just really things that I never knew. Like, having you share about, like, these are the nipples that are good, these are bad, this is the nursing bras that'll help, and the ones that are not as great. Like, I feel like we need a whole tutorial. I'm going to need, like, products for these mamas. Like, this is what Dr. Rachael recommends.
There's so much information. Like, oh my goodness, we spend so much money on things that don't work. Just don't spend money. And we don't need them. They don't work. Yeah. Really be careful about what you invest your money in. What I can tell you about what Robin, she studied in her PhD, was we talk about the golden hour often, but what we talk about is the 3 golden hours, because that hour often isn't long enough for baby to initiate the first breastfeed. Hence, everyone's under pressure and they start with the forceful techniques or introducing shields or whatever they do. It takes longer, and we would suggest delaying any non-urgent or procedures or unnecessary procedures. Establish the first breastfeed. Any injections, weights, assessment, so long as the APGAR is above 7 and you've got a healthy mother, healthy baby, the baby belongs in the mother's arms and we shouldn't be rushing, forcing or coercing that first breastfeed. So it can take up to 3 hours. Some babies feed within the first 10 minutes. It's normal, but especially those babies that have had a more difficult birth, take up to 3 hours to breastfeed. So long as they're healthy and everything is just fine, of course, we're watching as midwives, we're watching and assessing that and making sure they're fine. But we just give them the time they need to overcome their birth and just take a moment, have a sleep, adjust, and then they start to use those beautiful neurosensory skills. And in the hospital system, they like people in, through, and out really quickly. So women are often under pressure to get all the jobs done, tuck them up, off to the postnatal ward. But I would encourage women to say, no, thank you. The hospital management and bed problem is not my problem. It's your problem. I'm not going anywhere. I need time. I'm not getting this time back. I need to have an uncoerced, unhurried first breastfeed. And that first breastfeed is really important to ongoing breastfeeding. One, you don't want pain. Two, you really need milk moving through your ductal network so that you don't end up with early engorgement. And, of course, the first 3 days, 72 to 96 hours, 3 to 4 days, colostrum is extremely low volume. So you want to feed frequently back and forward between breasts to the cues of satisfaction. On around about day 2, maybe day 3, depending, babies, it's a lag time. So the babies often appear starving. They feed, they're unsettled. They want to keep feeding. Mothers are exhausted. They're starting to get teary, all those things. But it's normal, and the babies need to do that because they're stimulating prolactin from the pituitary, which brings the milk in. And this is often a time where people go, we'll just give it some formula, and then the baby feeds and it's heavy, it sleeps. So everyone says, see, they were just hungry, they just needed a little top up. Now they're not stimulating the breast because they're so full from formula. And now she's going to end up with engorgement because the baby hasn't been stimulating. So that's a real risk factor. So again, she's exhausted. She's so tired. She's just given birth. Everything hurts. It's normal, but let's support her by feeding mum and making sure she's getting sleep when she can and it's appropriate, making sure she can shower and toilet and do what she needs to do so that she can come back and breastfeed as often as the baby is needing to in a supported way.
And for these mothers, I'm just thinking of what you were sharing earlier with babies who are in pain will do the sucking reflex even if they're not hungry. So we've got babies who are also, moms think, they need to be fed all the time, every hour, I've heard some women say. And you're saying it's not actually that they're hungry necessarily, it's that they're in pain or there's digestive issues going on.
Yeah.
I mean, and there's just so much that impacts this journey of like mom's sleep, mom's exhaustion levels. Are they cluster feeding to bring that milk supply in? Or are they, agitated because they're in pain? So we think they're hungry, but they're actually having other issues.
Processing, So it depends on the age and stage. When there's still colostrum and the milk volume hasn't peaked yet, babies do need to frequently feed. It's constant. It's around the clock. It's
so that's just part of that process of getting that milk supply in. Yeah,
absolutely, really normal. Colostrum is extremely low volume. Frequent back and forward feeding stimulates the pituitary. It's lining the gut. They're getting all the microbiome from that. It's really
a miracle.
Important.
Yeah,
it's amazing. So amazing. But then once the milk volume peaks, then she can start to get a little bit of rest between the feeds because her baby will feed around about 7 to 8 times in 24 hours. And we encourage both breasts each feed. And that will reduce her risk of complications like block ducts, engorgement, mastitis, because the baby will take a small ratio, well, a ratio from this breast and then a ratio from this breast. They tend to take most from the first, some from the second, which is why we suggest alternating. So go left, right, next feed, right, left. And then you even out, and you're having milk flowing through both ductal networks. You imagine the bunches of grapes, and those ducts are full, and the oxytocin contracts those ducts. So if she's expressing, for example, now, and she's got a high volume, her breasts really fall under pressure, the baby can't coordinate what it needs to do. So they get the tongue and they push the nipple up into the hard palate. They push up, and then they use their gums to bite down, and that's where you end up with the lipstick-shaped nipple. And it's often misdiagnosed as thrush or Raynaud's, but it often isn't those things. So often women are treated for that, but it doesn't help. It's actually all to do with oral function. So really, not creating a problem is so important.
It sounds like we're creating most of our problems here.
We do. We honestly do. Honestly, Mother Nature is amazing. It's, she's thought of everything. And
it's kind of like birth. We just got to get out of the way and do it the way biology designed.
Yep. Absolutely. And occasionally things don't go 100% to plan.
Yeah.
And that's different. Yeah. Sometimes, women might have pre-existing health conditions, or maybe she's had a massive hemorrhage, or sometimes things don't go quite to plan. And, having someone really knowledgeable and experienced with you by your side on that journey with you, and again, continuity of care is really important. It's not just for labour and birth, it's for breastfeeding too. So you can see that follow-up and understand.
Yeah.
Often what happens is the hospital midwife back here has said, oh, look, you've got low volume, you need to be triple feeding. So breastfeeding, expressing and topping up. And then I might see a woman say it 6 months later and says, actually, I'm still triple feeding because my midwife back here said I had to, and she's not been given a plan to stop in a couple of days. And no one in the meantime has said, oh, actually.
Women should not be triple feeding for more than a couple days.
Oh, generally not. No. I mean, there's always time and place. I see a lot of babies who have had a frenotomy, and the latest trend is not now just to cut the tongue. They're now cutting the lip tie and the cheeks, and sometimes actually further back in the cheeks as well. So I saw one baby had the tongue, the lip tie, they cut another one on the bottom, and then the front buckles and then the back buckles. So it had like 8 incisions. This baby couldn't breastfeed. And the research is really clear, and the guidance, the professional guidance is very clear. None of those get cut. In exceptional circumstance, the tongue may need to be done. So baby couldn't breastfeed. So she was bringing baby to breast to try and keep that instinct, those neurosensory skills alive, and that the baby was having breast time in that experience and it wasn't forced or under coercion, and trying to use oral function, but couldn't stimulate enough to draw down a milk flow. So she had to express to protect her volume. She had to express and give the baby her express milk in the bottle. So that was long term. Now, in my experience, what I'm seeing is babies taking after frenotomy up to 3 to 4 months to heal from those injuries or those open wounds.
Wow. That's fascinating. I hear so much about that, and it's a controversial topic because I hear women saying it's a fad, professionals saying it's a fad, and others say, no, we are seeing an explosion of tongue ties and it's from the development in the womb. What's your take on that?
Well, it hasn't changed over millions of years. What's changed? Why are we suddenly seeing all these babies with it? It's just because I'm seeing health professionals whose specialty isn't breastfeeding. I'm seeing in Australia, there's a doula that markets herself as a tongue-tied doula, and that's just totally inappropriate. She's not a healthcare professional that can diagnose, assess, and intervene. I'm seeing a range of health professionals assessing it. Really, at the end of the day, one, I would suggest women see a a Thompson Method practitioner who can sit down, assess and diagnose a breastfeed. Even babies, just even an example, my own third baby, he was a free birth on my farm and he had a grade 4 tongue and lip tie and went and breastfed for 3.5 years with no pain, no trauma, no speech, no nothing, no problems, just went on and breastfed. It's normal. It's a normal variation. It's a genetic condition. It comes down the lineage. So understanding paternal and maternal genetics is really important. And then you're looking at, speech problems, babies aren't speaking. They can have it done by a specialist ENT under a general anaesthetic when it's appropriate. And that's appropriate. Not as a newborn and young baby who's solely relying on their tongue to breastfeed. And then they're doing all these exercises, stretches, which is extremely painful and they increase scar tissue. The evidence is actually very clear, but there's a lot of very low evidence that people are quoting and using to promote their own agenda. And I think that's something that's just absolutely not professional. The explosion of dentists who now carry laser because laser is very cheap. The cost to do an incision is very cheap to do, but it's a great money grab. And they're charging a fortune. In Australia, I think it's roughly about $600 per incision. Now, I'm seeing babies having often up to 4, 6 or 8 is not so common, but 4 is very common. So tongue, lip, cheeks, 3 times each because it's not resolving the problem. But it's not the problem. The problem is the hamburger hold, the big wide open mouth, the holding the back of the craniocervical spine and inhibiting oral function. And then it's all the things that they're saying around that. So a tongue tie causes hiccups. No, it doesn't. Hiccups are normal. We all hiccup. Babies hiccup. They hiccup in utero because they're drinking amniotic fluid. They hiccup after birth because they're so short through top of shoulder to tip of hip. And they have the hiccups. That's a normal spasm.
Wow.
Babies can't swallow air. That's not a thing. They're not swallowing air. So having a tongue tie doesn't make you swallow air. There's a whole, honestly, I could go on and on about it, Karen. There's so many things. It's just a lot of misinformation and health professionals aren't understanding anatomy and physiology. And for every argument that they're saying it's important, I can give you a really well-versed, educated, academic resource, why it's just not necessary. So in America, the procedure's gone up nearly 900% in the last 10 years. In Australia, it's gone up around about 400% in the last 10 years. There's one state in Australia that went up, I think it was 3,000%. That's crazy. Like, that's not healthy statistics. Like, it should be controlled and audited and who's doing these things. But actually, that's not happening.
Yeah, there's not a lot of regulation.
Not at all, and not anywhere. So, 900% in 10 years is a massive increase.
Certainly some really important things to think about and research for women who are encountering, tongue ties or potential tongue ties. So thank you for sharing that. That's a great perspective. And knowing that there's other modalities, there's other techniques to explore first, with like what you're recommending is, and just making sure you're breastfeeding properly with proper technique and alignment is so important. Tell us just really quickly, I know we're running out of time here, but I would love to
we could talk forever.
I know, I can tell. Like, I feel like we're getting a master class on breastfeeding. Like, this is amazing. But there's so many myths and so much misinformation that we could talk for hours because,
literally,
like you said, it's just women don't know because they're going to professionals, they're physician, the nurses at the hospital, the lactation consultants. They think they know what they're talking about, and they're not breastfeeding experts, like you said. And even variations of advice between different lactation consultants and international board certified lactation consultants or their midwife, and you just don't know who to trust anymore. And so I so appreciate your expert information on all of these topics. And I wanted to ask you about insufficient glandular supply. Tell us about that. Is that a thing? Is it overdiagnosed? What can women do who might be afraid of that or have, heard that they may have that.
It is something I see overdiagnosed. But firstly, I would say to women, you don't know until you test it. So first we test it. I'm going to sit with you. We'll watch a breastfeed. We'll talk about it. Just because you've got small breasts doesn't mean you have insufficient glandular tissue. But let's talk about your history. Have you had breast development? Have you got anybody in the family that has medical conditions that inhibited breast growth? And there's a few. And often we would know about these things in pregnancy. If she's breastfeeding when she comes to me, we watch a feed together. And that's the best thing. I mean, really, you can't look at someone's breast and say you've got insufficient glandular tissue, because sometimes women, that's just her unique genetic breast. And actually, if you went on that alone, it's actually incorrect, because she can go on and breastfeed quite normally. Yes, there is a particular look. They often are conical, or they don't have, they're widely spaced and things like that. But again, that alone isn't enough to diagnose, because some women have breasts like that that's normal genetics for them, but they go on and breastfeed okay and do have a normal volume of milk and sustain breastfeeding. Some women do have insufficient glandular tissue, and I really hate that word insufficient, because nothing about mothers is insufficient. So maybe just
Amen.
not
So true. That's a good right there. That's just you are not insufficient.
You are never insufficient. It's like a failure to thrive, and
the language we use.
Oh my goodness, it's awful language.
Yes,
but never
ever
am I going to use that language, because you didn't fail, you didn't anything. You just did what you could, and you're doing what you can, and you're perfect. Look, into those women that don't have the breast growth to sustain glandular development, to fully breastfeed, they may need to give a volume of formula or donor milk, whatever she's using, to the observed cues of satisfaction. So she can breastfeed, and she may need to give an additional top-up of whatever she uses, and that's okay. She's doing what she can, and that's okay. Some women can't breastfeed. Some women have had bilateral mastectomy. They don't have breast to breastfeed. And that's okay. Let me help you bottle feed in a way that your baby isn't going to have reflux and colic. Women do the best they can with what they've got. So, but most women can breastfeed if we look after them and nourish them and not overwhelm them and put them under duress and pressure, and do less and not more. I'm seeing women who literally aren't going to the toilet. They're not showering. They're not eating, and they're not enjoying their babies. We're seeing more anxiety, more depression, more maternal suicide. It's one of the leading causes of maternal death than ever before in history. What we are doing is not working, and it's actually wrong.
It's true. I just saw the ACOG report, and for the U.S., certain populations of mothers, I think, are the highest rate of death is maternal mental health categories. So suicide or connected to maternal mental health, and, not hemorrhage, not medical things. It's like, wow, this is a really big issue, and we're seeing that skyrocket. So how much does stress and anxiety contribute to breastfeeding issues?
It's huge. I'm seeing women from every continent over the globe, and women come to me highly distressed, highly emotional. They've sought other health professionals. They're doing all of these interventions. Sometimes they're warranted, but most often they're not. And often it's pain and the pressure of, needing to be the best mother without help, without support, doing it all on my own. But the conflicting, confusing advice, she's just at her wit's end. She doesn't know who to trust anymore. And it's all overwhelming. So women are being medicated. Often they don't, if we can take away all that pressure and have her spacing the feed so she's getting a rest. It's important she has a rest during the day. She's healing from pregnancy, labour, birth. Absolutely. Yeah. But in modern healthcare, the mum is no more than a vessel and someone who feeds a baby, and she's invisible. And that's really not okay. It's two people, and they're both equally as important. And we need to hold her so she can hold her baby. And that is really important. If we can get to the root cause of those problems, for most women, the anxiety eases up or disappears. The depression disappears. She doesn't need to be medicated anymore. And she's breastfeeding. And then she's got all those beautiful hormones that sustain breastfeeding and mood and all those things.
Mm-hmm.
And that's what we want.
That's exactly right. And I agree. Like I love how you said it. We need to hold mom so she can hold the baby. Yeah. And we come in to like meet moms and we go, oh, let me hold the baby for you. No, support mom. I tell women, like, support her, cook her a meal, do her laundry, let her take a nap, but like support her so she can nurture baby.
Do what she needs to do. I think you hit the nail on the head. Like, we come in, we take over, we take the baby, or as health professionals, we want to help the baby feed, so we're grabbing her. I see women who have hand marks on their breasts from the midwife who comes in and grabs them, and often without consent, and says, I'll show you how to do it, you're doing it wrong, and they take over. And that's really awful. She's not doing it wrong. She's doing it the way she feels she wants to do it. And there's nothing wrong with that. So, we need to follow her intuition. Her intuition is always right. And we can help to guide her and to nurture her and to help her understand, various things along the way. But instinctively, women sustain pregnancy. We give birth instinctively, intuitively. We breastfeed in the same way. You'll never see a woman breastfeed using cross-cradle hold who hasn't been taught that. No woman will instinctively go to hamburger her breast and jam a baby on. And everyone says it feels awful, but that's what I was taught. And they all go, oh, wow, that doesn't hurt. And that just feels so natural. And I feel so comfortable.
You mentioned the hormones being released from the mom when she's supported, when she's, able to bond with her baby and get those important hormones of oxytocin and prolactin. And we see that in birth. And that's what I tell women is like, there's a blueprint for birth and there's a blueprint for the postpartum, and it's the hormonal physiology. And if you're not getting those releases and those hits of prolactin or oxytocin and in those stages, your body's not going to function the way it's created to. You're going to struggle. Your baby's going to struggle. And when we honor that design and we support our hormones, our emotions, everything gets easier. And like you said, do less. Like, women are doing so much.
Well, if you look at it like this, to have great sex, right, you need to have that, that mindset. You're safe, you're protected, you're kind of in your little bubble. If to give birth, it's exactly the same.
And thank God we have women like you helping us understand how to really navigate some really tricky situations. So I just want to give a shout out to you for the Thompson Method, for the breastfeeding courses that you are offering. And we have an incredible offer for you guys for listening to this podcast to get their the birth and breastfeeding course for 50% off. And so we're going to put the link for that in the show notes. Make sure you're preparing for postpartum, ladies, not just birth, but we have just such a beautiful, wow. I feel like we just got a download of like so much valuable knowledge. And I just thank you, Rachael, for generously sharing with us your wisdom, your years of experience, and from the products to how in navigating these tricky situations. And is there anything else you would just want to encourage moms with who might be struggling right now in the postpartum with any of the things we've talked about today? But what would you just share with moms, either pregnant or postpartum?
I would suggest if you're pregnant, please invest in breastfeeding education. It's so important. You're less likely to have problems in the postpartum if you do your education. Most first-time mums just try and wing it and think, oh, well, it's normal, it's natural. Yes, it is, but in our current healthcare system, it's not. So most first-time mums are focusing on labour and birth, but they forget about breastfeeding. So please focus on breastfeeding as well. It's really important. For breastfeeding mums who are struggling, the program is great, but if you need more support, a one-on-one consultation with either myself or one of my amazing team would be there probably to help you one-on-one, to take a history, to watch a full feed, and to get you back on track a bit quicker, so you're not on your own. But the pregnancy and breastfeeding course is self-directed. If you're pregnant, perhaps do modules 1, 2, and 3. And that doesn't take you too long, maybe a few hours. and focus on that. And then the other modules are once you're breastfeeding and go through the relevant ones only. Yeah.
Yeah. Thank you for that. We'll put the links to all that in the show notes, and as well as how you can contact Rachael Austin or her team. And thank you so much for sharing today, Rachael. We'll see you guys next week.
See you.